The first event of 2018. We're going to, because next month is our annual mega code and pit crew practice sessions in the skills. We're going to go over CPR science, cardiac arrest. I'm also going to talk about some, I think, minor changes to the standing orders, and a couple of housekeeping kind of things, and a few different case reviews, which all relate mostly to cardiac arrest kind of things. So, right in the batch, talking about cardiac arrest. And we're going to be working to make our experiences in OTEP and PCEP count for your, quote, merit badges in ACLS, etc., just like we do for trauma, which will save some things. Now, I'm not going to speak to the crowd here, but I'm just going to pre-warn you that some other changes are coming soon, because National Registry has changed their rules. And National Registry is now allowing you only 10 hours per period of distributive learning, which means watching the tapes. So there's going to be, of that 48-hour refresher, you can only count 10 hours of tape review. So it'll have to be online, it'll have to be in person. So we'll be talking at the next QI meeting about how we're going to adjust that. We may be going back to the 2 days, every lecture have 2 different days available, so that all the shifts can have the opportunity for learning. Any rate, more news at 11, as they say. So the principles of high performance CPR, EMTs, and you guys are EMTs even though you are EMTPs. EMTs own CPR. We're still the best people to do CPR. If you want to have a heart attack, if you want to have a cardiac arrest, do it in front of a fire station or an ambulance station. Minimize interruptions in CPR at all times. Ensure proper depth of compression, which is now 2 to 2.4 inches. Now, 5 centimeters. Are you going to, are we going to measure? That's why we practice with a feedback machine. Now, there are devices out there that will give you feedback, compression depths. We don't have a lot of those. So for us, practice makes perfect. The Seattle Fire, when you watch them work, any one of them can reproduce a perfect strip every time on any mannequin, on anything. And we assume that applies to people too. Ensure full chest decompression, recoil. Ensure proper chest compression rate. Our rate's 100 to 120. We like to say 110 is a nice number, right in between. Rotate compressors every 2 minutes so nobody gets fatigued. We hover over the chest, getting ready to compress as soon as the patient has cleared, before the shock, after the shock. We're trying to reduce this to less than 10 seconds, less than 10 seconds. Intubate and place advanced airway with ongoing CPR, put an IV or an IO with ongoing CPR, coordinate teamwork between the EMTs and the paramedics. The EMTs own it, though. So, high performance CPR. Establish unresponsiveness, pulseless apneic, we're having the telephone, the dispatchers do not ask now, hopefully, whether they simply say, are they breathing normally? That way agonal respirations are still treated. You know how to do CPR, one hand in the middle of the chest, other hand on the back, lock fingers, push down 2 to 2.4 inches, 110 per minute. CPR is the foundation of resuscitation, and high-performance CPR improves the effectiveness of defibrillation and effectiveness of medications. The likelihood of ROSC in return of spontaneous circulation increases significantly with higher mean chest compression rates. So studies show people get ROSC with 90 or more chest compressions compared to 72 or fewer chest compressions. So it still has not been, quote, scientifically proven which is the best. And people are saying, well, maybe we can do 90. And you know why they want to do the 90? It's because the Lucas machine can't exceed 90. ROSC decreases with compression rates above 130 though. So the sweet spot is somewhere between 100 and 130, and 110 seems to be as good as any. If you're at 120, you're fine too. And remember, if you're at 120 per minute and you have you do a set of 200, which is a little less than 2 minutes, and you take a 10-second pause for interpretation of the rhythm strip and perhaps giving a shock, then your rate is actually effectively only 110. So that's what we're trying to do. Better compressions lead to better organ perfusion. So greater depth of compression increases the likelihood of a successful shock. Compression equals organ perfusion. You push down and you push blood forward. You perfuse organs. Decompression produces negative intrathoracic pressure, sucking blood into the heart, into the thorax, into the heart, so you can compress and push it forward. You need to have enough compression, decompression to be able to get your aortic pressure. The difference between the end-diastolic aortic pressure and the right ventricle pressure has to be about 25 in order to be able to actually pump blood forward effectively. Pausing makes a difference. The longer the pause in chest compression, lower chance of positive outcome. Here's the very simple experiment. This was pigs. I have to say, they didn't do this with people. These were pigs, and they had literally 100% resuscitation if their pauses were only 3 seconds. If their pauses were 15 seconds or more, they have only a 40% recovery. Now, you say, gee, 40% recovery in VFib is pretty amazing. Actually, we actually approximate that for witnessed VFib arrest. But this is a totally controlled thing, so you expect resuscitation. So the only difference here is the time of pauses. And the time of pause is very simple. I mean, makes sense because during that pause time, there is no coronary flow because there's no difference between end-diastolic aortic pressure and right atrial pressure. So there's no flow whatsoever through the coronaries. So your coronaries are not being, so, 15 seconds of no coronary flow, you start killing more heart muscle. Doesn't return. The longer the pause preceding the shock or following shock, lower the chance of survival. Sheldon Chesky, who is one of the researchers from Toronto, has done some really nice studies on that. And this is why we teach the system of telling your evaluator, defibrillator, when you reach 180 to start anticipating that they have to do something. At 190, we charge the machine, and at 200, you come off. There's no pause then, and you should be able to see VFib in about 3 seconds. Deliver the shock. That could be a 5 to 6 second delay then. Even if you take 7 seconds to evaluate that rhythm and you deliver a shock, it's only 10 seconds then. Incomplete decompression, I've already mentioned it. Inadequate blood volume in the heart and lungs. 75% decompression doesn't provide enough coronary or cerebral perfusion to achieve ROSC. Yiannopoulos is a very interesting guy of obviously Greek extraction. He runs the cardiac research lab at the University of Minnesota, and they're the ones who are taking selected persons in refractory VFib they put them on ECMO, essentially heart-lung bypass, and take them to the cath lab. And they've got reasonable results from that. Now the patients are all transported to the hospital using a Lucas machine to do compression, because you can't do really adequate CPR in the back of a moving rig over any length of time. Inadequate decompression compromises both coronary and cerebral blood flow. Even limited periods of incomplete decompression has a lingering effect. It lasts. I mean, you just don't have coronary flow. So the Canadians say, they don't call it adequate, they say don't park or camp on the chest. So you have to have complete decompression. Okay, what about medications? Medication is the last thing, and it's still the most important thing, is early CPR, early defibrillation for the person who's in cardiac arrest with a shockable rhythm. Perfusion is the mechanism that circulates medication. The better perfusion, the better circulation. Good CPR decreases by about 200% the amount of time required for circulating blood when compared to poor CPR. Now, the takeaway for me on this one is also that because good CPR maybe gets you 30% circulation, it takes a long time to get from a very peripheral vein into the general circulation. What's the most peripheral vein that we do? It's a IO in the tibia. So the most proximal vein that we do is actually the humeral head. So if you have a cardiac arrest, if I had a cardiac arrest, I would prefer that you do an IO. If you're going to do an IO, if you can't find a good antecubital vein, do an IO in the humeral head. Good. We showed in one of the side studies that occurred out of the ALPS study was that there was a slight decrease in ROSC, a trend to decrease in ROSC from IOs compared to IVs. And that's because almost all the IOs in the ALPS study were in the tibia. It takes about 1.5 minutes to get from the tibia into the general circulation when you're doing low flow states like CPR. So if you can't get it into the humeral head, obviously the tibia isn't, but anticipate your medication is not going to do anything for 1.5 minutes. Early defibrillation studies. Every study out there says AED shock by bystanders for initial VTAC VFib arrest is associated with greater survival with good to excellent functional recovery and results in the use of less medications. And we have several cases of our own where people go down, witnessed generally in a gym-like situation where they have an AED, they have people that recognize they went down, they put the AED on, they shock. Last lecture, one of our case reviews was the 15-year-old girl who went down at school. The bystanders, which happened to be school nurse and the sheriff, put an AED on, single shock, she was back in a perfusing rhythm. Of course, they use less medication then, because when do we use medication? When they're refractory to shocks. All right, one of the side effects of one of the things we did find in the Rock Alps, if you had a witnessed arrest with a shockable rhythm, those patients, the rate of survival to hospital discharge was significantly higher with either amiodarone or lidocaine, about the same, no difference, than with the placebo. So give or take, almost 28% of the people survived in a witnessed shockable rhythm, refractory to the initial shocks, but who got lidocaine or amiodarone. So 28 out of 100 went home, whereas only 23 of 100, so 5 people per 100 difference. So it does seem to make a difference. And it was consistent across both amiodarone and lidocaine. Now, then, paper we just published, whether or not the arrest was initially shockable or not, if they ultimately became shockable and then were refractory, there was a consistent trend towards survival with either lidocaine or amiodarone. Actually, amiodarone was a little bit better in this one. They were not statistically significant, but there's a definite trend, which we can say. So this goes, so if you get their patients in PEA or asystole, you get with epinephrine, et cetera, you get them back to a shockable rhythm, you shock them, they stay in that shockable rhythm. It does pay to give them some amiodarone or lidocaine. We use amiodarone. It seems to make a difference. Yeah.
So that previous slide from my math showed 0.1% improvement with lidocaine over amiodarone. And if they're so comparable, what is the reason that we're doing the amiodarone instead of lidocaine? I mean, lidocaine's easier to push. You don't have to draw it up. It's metabolized. It seems like a little easier on your body.
Well, one of the side effects of, in the original ALP study, one of the side effects of, that we were able to, when you looked at the numbers of all the side effects, we were able to predict, without knowing which the drug, just by the side effect, which drug had been given. So the patients with lidocaine had more seizures afterwards, and the patients with amiodarone required more pressor support. And that was the significant difference. So, you know, it's true, there's no great difference. Now, why do we use lidocaine, why do we use amiodarone instead of lidocaine? Because we use amiodarone for other things too, you know. The problem is the formulation we used in the ALP study is not exactly the formulation that's available commercial. And there are some downside, but we do use amiodarone for VTAC now. We use it for pulsed VTAC. We use it, you know, and it's much more useful for treatment of atrial arrhythmias, particularly if you have wide complex aberrant conduction. So that's really the only thing. If you decided right off the top of your head that, oh, I want to use lidocaine today, I wouldn't have any big argument about it one way or the other. But I prefer you to do really good CPR and stuff beforehand and not have to get to give medications.
And I prefer to stay out of your office.
Yeah, yeah, that's a good idea. It's but we're not even going to have an office by the end of the month. Okay. So, survival from VF-VTAC after initial non-survival out of hospital cardiac arrest is poor, but not negligible. So that's why we continue. So the whole point of having an asystole is to try to get them to either to come back with an ROSC spontaneously or get them to a point where you treat them for a shockable rhythm. Teamwork, teamwork. Teamwork is the key. So collaborate, communicate, coordinate, increase focus on using a team approach during resuscitations. You do interventions simultaneously, minimize interruptions in compression, clear communication. High performance CPR begins with the foundation of EMT CPR. Advanced cardiac life support is layered on it with the teamwork by the EMS crews. So pit crew approach is what we have elected to do. Now, it's simply an organizational method for managing resuscitation with predetermined assigned position responsibilities. The number one priority, though, of all personnel is to maintain high-quality CPR. Minimal interruptions, no interruptions less than 10 seconds. You may have to adapt the pit crew. The pit crew was designed for cities that had adequate response. They had a minimum of 5 to 8 people responding to a code, ultimately. When you have smaller responders, smaller number of responders, you adapt the pit crew to what works. So, pit crew CPR can only happen when you get the patient to a place where you can actually get 5 to 8 people around them. So in the tiny little bathroom with the guy stuck behind the toilet, you can't do pit crew CPR. You can't do anything in there. Well, you can do anything. That's why he was in there. If they're limited rescuers, North Country, a few at a time, CPR and defibrillation are the first priority. All other activities are accomplished with additional resources. Incident command principles are followed. That's fire-based incident command. So, basic, first arriving paramedic is the team leader for the resuscitation. First arriving company officer is the, quote, fast attack incident commander. It's not something I am comfortable with. Fast attack. They're responsible for the non-medical management of the scene, safety, and liaison while assisting with the resuscitation. Second arriving company officer, strategic incident commander, non-medical management of the scene from the tactical IC, remaining strategic but uninvolved in resuscitation if possible, if there's enough people. He's the one who's going to plan your egress mostly. Position 1, compression, determine cardiac arrest, pulseless apneic, etc. Expose the chest, begin compressions, announce when you're at 180 and then 190 and 200. Now that takes practice to get, first of all, you've got to be able to count. And you have to be able to remember to do that. And all you're doing is warning the guy who's going to be in charge of the defibrillation and evaluation. Position 2 is life pack. Turn on the life pack to timestamp it at the for the beginning of CPR. That's when we say you are beginning CPR, at patient beginning CPR. The metronome is generally built into the machines. Keep the metronome on, it helps you to count. Apply patches. Now, I prefer AP placement. I think it works better. If you're having, in the hospitals now, if all the manufacturers for cardioversion recommend AP placement. I think AP placement catches the heart much better, but I am very well aware that sometimes you don't have the ability to do that. It takes a little time to pull that shirt off, roll a giant person over, and be able to put an AP patch on. So you do what works. But I think we're going to get better result with AP. Now, if you haven't put it on, if you've already given them 3 shocks in the refractory, if possible, put AP, change it and put AP on. You know, in Portland, they drag in another monitor defibrillator and put AP patches on, and then you have 2, and then they try to give simultaneous shocks. That doesn't make any sense to me at all. First of all, you can't give simultaneous shocks. No machine does, push that button, no one really does simultaneously. And I think it's just that they now have an AP placement. But Dr. Jew disagrees with that, although, so at any rate, my money is go to the AP. We're not going to drag another monitor in right now. So monitor compression quality, speed, time intervals, charge the monitor at compression 190. So this is 180, the person in charge of that defibrillator. Number 2, charges the machine when you get not 190. At 200, you come off, you look at it. If it is not a shockable rhythm, dump the charge. Put them right back on the chest. If it's a shockable rhythm, shock. Put them right back on the chest. Another compressor. Alternate doing compressions. Now, so position 2, if there's only 2 of you there, position 1 and position 2 can alternate if you're going to get tired out. Now you say, well, wait a minute, am I going to put a, well, it depends. You have to say, if you've got 2 paramedics, that's easy because you can read the machine. And there are only 2 of you there, your machine should be in what? it should be in AED mode. That way, an EMT could do it. Machine will read it. Say shock or not shock. Position 3, airway. First thing, O2 via nasal cannula at 10 to 15 liters per minute. That gives you apneic ventilation potential. Then BVM ventilation after the first defibrillation. So in the first moment of being there, you need just compressions. Now, you can put an iGel in after the first or second defibrillation, so you've gone through at least one sequence. Provide ventilation, try to do ventilations on the upstroke so that when they're in the decompression, now, it probably doesn't make any difference. And it doesn't make any difference once you get a decent airway in, such as an iGel. Attach the ETCO2 to the iGel, you can tell if you're really getting ventilations then. Suction is needed. Intubation should be done if you need it for airway control. It doesn't interfere with compressions, or you get ROSC and you are transporting the patient and he's not awake and talking to you. You don't need to intubate him if he wakes up and says, "Get off my chest." Position 4, compressions, alternate compressions. So now we've got 4 people there. Position 5, IV and IO meds. Now that might be position number 2 if you only have 2 of you there. One IV attempt. If you can't do it, do an IO. Remember, practice, practice, practice. I'd like to see more in cardiac arrest and trauma. I'd like to see more humeral heads. We need to do more practice. You may have to practice every month to feel happy about it. If you're 100% sure that IV success is unlikely, then go right to an IO. But you can do that by observation. You know, if they don't have any arms, you're pretty well sure of that. And you probably can't do a humeral IO then either. Administer required medication. Position 6, the strategic IC. This is the one who's really not involved with the actual mechanics of CPR. He's safety, she is safety, liaison with family and other agencies, getting medical history, getting drug history, etc. Develop a plan for egress. Position 7 and 8, backups. They're there to be assigned as needed. So this is kind of the positioning, schematic of the positioning with your strategic IC and your backup folk hanging out below. As far as I'm concerned, I think it works better with the compressors to be on either side so that you can switch off. But that makes no difference. Yeah. So, practice, see what works. In the hospital, I always like to have one on one side, one on the other, so there's no delay. But if you can really scoot around, you know you're going to have a 5 to 10 second delay before you have to start compressing again, so you can move. After the incident, now this is where we are falling down lately. Company officers should debrief the crews after each cardiac arrest crew and determine where improvement can be made in the application of the standing operating procedures. All personnel, and that includes all personnel in the case, so that by argument then, by inference, that means AMR and fire. Should review the CPR process, the CPO file, and determine how CPR can be, you do a hot wash of the incident to decide what went well, what could be better. And even if you get ROSC, there's almost always, in any human endeavor, there's always something you say, well, I might have been able to do this a little bit better. Even though you can't argue with the outcome. So, remember, EMTs own CPR, minimize interruptions in CPR, ensure proper depth of compression, 2 to 2.4 inches, ensure full chest recoil decompression, rotate compressors every 2 minutes, hover hands, be ready to compress as soon as the patient is cleared, intubate or place advanced airway with ongoing CPR, place IV or IO with ongoing CPR, coordinate, and teamwork between EMTs and paramedics. Our walk cares is our cardiac arrest registry to enhance survival. Oregon, most of the Portland area now is on a CARES system also. Salem, I think, is on a CARES system now. It's developed to help communities determine standard outcome measures for out-of-hospital cardiac arrest, for quality improvement efforts and benchmarking capabilities. We have a data tool that allows us to identify trends, to have training opportunities, compare with other national sites. But it's imperative that our data input is accurate, which is what we depend on you to fill out your charts adequately and also to have the PCO file. These are the current care sites. Although they've been expanding into sections of California, sections of Arizona, and New Mexico. So it's getting around, it's getting to be a pretty much of a standard. So this is our summary of Clark County out-of-hospital arrests from 2013, 2014, 2015, 2016. So we've got 4 years of this. The pink is survival to discharge, and you can see that the survival to discharge has been trending upward. Now, you say, well, not a huge amount. Well, this is 14% to 19%, almost 20%, which once again is a difference of 6 persons per 100. Our sample size is not huge, so you can't make a lot of determination on that. And you can see that our sample size has actually decreased since 2013. Which I guess we can only interpret not as many people are having cardiac arrests or calling us in that amount of time, and I don't really know how to explain that part. Our ROSC has gone up, our survival to admission has gone up, although both of those trended down a little bit, but not significantly with our N number in 2016. Now, just empirically in our gestalt right now is that our survival to discharge rate is actually decreasing this year, and we're not 100% sure why. We have a couple of thoughts, and I would be happy to entertain any comments from any of you as to anything you've observed on cardiac arrests, and maybe just the demographic of the patients. They may have more comorbidities. They may have. It may also be the fact that we are not doing the ALPS study right now, and there's a whole advantage of people knowing you're being looked at to how you perform and wanting to perform to something.
Do these numbers, these represent all the patients that initiated care on?
Yep, all the patients that had intent to treat.
Everything with intent to treat?
Yep.
Even though they weren't even transported?
Mm-hmm.
So, okay.
Oh yeah. No. These include all the treated who were in asystole and never got out of asystole. You left them.
But no obvious deaths? No one where we never initiated?
No. And these are non-traumatic cardiac arrests. So
the criteria for law care's submission for medical only cardiac arrest, cardiac specific, is anytime an EMS provider instituted CPR. There's even a category, so if you institute CPR and they throw out a pulse form or a DNR order, then you stop. There's a criteria for that as well, and that's measured a different way. But anytime an EMS provider institutes CPR, it gets included into law care.
Does that include the narcotic overdose?
No.
nope.
Right. If it's a,
Narcotic poisoning are not counted.
so I would caveat with this, it's imperative that you, and most of the time it's actually, you guys do an excellent job of giving the reason, because there's typically a question, reason for call or reason for arrest or whatever the question is. Most of the time you do a pretty good job of that, I don't have to guess. So it's, if there's clues on scene that say this is a traumatic event, this is a, and sometimes it's not so obvious, or this is a medical event, it's important to know the difference between the two. And the other thing is, with your charting formats, there's a question in there for cardiac arrest on estimated time of arrest. That's a data point that I have to fill out. You have a better idea of when that is than I do by reading your chart. And that's a data point that needs to be filled out for every one of these cardiac arrests. We have to know, something educated on when
Right.
you think their arrest time was. And it doesn't make sense if somebody says to you, if a bystander says, family member says, well, I last saw him at 11:30 last night. Well, now it's 6 o'clock in the morning and you have a guy that's in VFib and, agonal respiration. Well, he probably didn't go into cardiac arrest at 11:30 that night. So with your best educated guess, I need to know when you think you went into cardiac arrest. So I'm done. Thanks.
You can say greater than 10 minutes even, or whatever, or give a time.
I need a specific.
You need a time.
Yeah.
But if it's a witnessed arrest, you can put the time that they called. Okay, really quickly, just covering a couple of cardiac things out there that we see. We've got the life vest, the Zoll life vest, and I think there's another manufacturer now, is a wearable defibrillator for patients at risk for sudden cardiac arrest, where their physicians haven't yet decided that they're going to take them to the cath lab and put in an implantable internal cardiac defibrillator. I'm always a little bit curious. There's sometimes some very good reasons for not doing that, but I'm not sure, other than insurance, why that sometimes occurs. But some patients are not good candidates for, if you're not a good candidate for a cath lab, I guess you're kind of in trouble anyway. It's non-invasive, consists of a garment and a monitor. The garment detects arrhythmias, delivers treatments and shocks. Monitor monitors rhythm, contains the battery. You can be shocked by this device yourself, just like you can be shocked by any defibrillator. Now, will it kill you? Probably not. Will it surprise you? Definitely. Don't touch the patient when a shock is being delivered. The life vest warns you and any bystander with a siren alert and a voice command saying, electric shock is possible, don't touch the patient. Bystanders do not interfere. It gives you a warning. It's just like your partner. When your partner says, I'm clear, you're clear, we're all clear, that means you're not touching the patient. Can you use an external defibrillator while the patient's wearing a life vest? If the thing isn't functioning correctly, yes. Disconnect the monitor from the electrode belt. What if the patient feels a vibration coming from the vibration along with the alerts and voice prompts? That's part of the life vest trying to figure out if the patient's conscious. So they can press and hold the buttons to avoid a shock. Now, so if the thing is vibrating, it's going to give a shock. Stand off at that point if the patient's unconscious. This machine's trying to wake him up and see, hey. So, couple tones. If it's silent or a single tone, or if it says contact the physician or treatment has been given, call your doctor, that means it's monitoring the patient and it's alerting the patient to follow instruction on the scene. If the patient's unconscious, you're watching the screen and it says, hey, I'm going to treat this patient.
Treatment's been given means they've already been
Shocked. If there's a two-tone siren alert, it means if the patient's not responsive, the voice will say, call for help, perform CPR. Or device disabled, call ambulance. That's what it'll tell the caregivers. That means the device can't detect the rhythm, or the device has delivered as maximum amount of treatments that it can. Some of these devices are set to deliver 6, some of them are set to deliver 9 consecutive shocks. Remember, these are very low dose shocks because they're external, but they're not the same as your, it's probably less than 200. Two-tone siren alert with a voice saying press response buttons to delay treatment, or there's a vibration, or it'll say electric shock possible, don't touch patient, or bystanders do not interfere. It'll say any of those things. That means it's detected a ventricular arrhythmia and it's going to shock the patient. So stop CPR at that time, stand back. If the patient's awake, they can press the response button to stop it. Standard evaluation treatment measures, CPR can be performed as long as the device is not broadcasting press the response buttons or electric shock possible. If you're going to use, if you say this thing is just not working right, or it's given all the shocks, remove the life vest by first pulling out the battery, then take the garment off, and then you can use an external defibrillator. I'm not going to talk much about LVADs because they're all so different. The takeaway with the LVAD is anybody aware of anybody in there? Okay, we've got one over here, you've got one over there, and 2 over there. So we've got, and each crew, each area, the crew should be updated on what LVAD is out there in their area. And the LVADs all have a phone number to call. And you need someone on the phone talking to the LVAD coordinator who can troubleshoot some of that yourself. Most of the people, their caregivers have been given reasonable instruction on how to troubleshoot. The LVAD assists the function of the left ventricle, propels blood to the ascending aorta, It uses an external wearable system that has a controller connected to an internal pump by an external drive line. It's powered by 2 batteries. It can also be plugged into a 110 power, or 12 volt for that matter. If a patient has a problem that has an LVAD identified, establish airway, provide O2 if any respiratory symptoms. It doesn't necessarily mean there's any problem. If they're having a medical problem, they have all sorts of medical problems, so they may not be having a problem with the LVAD itself. Do a thorough patient evaluation, including device function. So the major causes of problem may be infection, volume depletion, shock, stroke, bleeding, and dysrhythmias. Most patients are anticoagulated, so they're at risk for bleeding. Auscultate the heart sounds to determine if the device is functioning. If it's functioning, you should hear a whirring sound, because not thump 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 thump, but because it's a continuous flow device. Therefore, you may not feel a pulse because there's no difference in the flow at any time in the where you normally feel pulses. Now, if you feel over the carotid, you may feel what's called a thrill. You may feel flow. Assess for other things: cap refill, mental status, dizziness, temperature of skin, moisture of skin, etc. Cool, clammy. EtCO2 is a good thing. If their EtCO2 is normal, it kind of indicates they're perfusing. Treat with fluids as needed, large bore IV. Your standard blood, you may not be able to get a blood pressure. So end-tidal CO2 and capillary refill, mental status. Pulse oximetry probably won't be accurate because of the continuous flow also. Because the way pulse oximetry works is it's a comparison between the colorimetric change between systole and diastole. Now, an EKG will probably be reliable. You can tell if they have ventricular dysrhythms, and VFib may not be symptomatic because they don't depend on the heart beating entirely. If the patient requires defibrillation, leave the pump running, leave everything in place, but don't place the defibrillator directly over the pump. Or if they have a pacemaker, don't put it right over the pacemaker either. Most of your pacemakers are up in your left-hand side anyway. So this is another place where you can use AP placement if you had to do it. Any ACLS medication may be in there, any medication for anything else, any other medical condition that you have medication to treat. Don't perform chest compressions unless the VAD center, the ventricular assist center, tells you to do it. So that's why you need to be on the phone with that coordinator. Chest compressions if the pump isn't working. When you transport the patient, they go to the closest LVAD or closest hospital. So Southwest can manage, in a pinch, can manage it. If the patient is otherwise stable, take them to where their LVAD was put in, which is usually OHSU. Now, unfortunately or fortunately, we have a couple patients in the area now who came from Seattle. So they'll end up going to Southwest. We're not asking you to transport to Seattle yet. Follow the advice of the coordinator to troubleshoot. Remember that the patient has to be supported by battery power, so transport the backup controller and the spare batteries with the patient. Yeah,
if you're in a rest. Because they can't push against the artery constriction.
right. Did you follow that? Cut your doses of epi or any other pressor drug in half, because if you get increased peripheral resistance too much, then the LVAD, it's a very low pressure system. It can't pump against it.
Should the coordinators be somewhat familiar with talking with us, like if we call?
Oh, yeah. Yeah,
They're
and,
gonna be able to walk us through some of that.
yeah, and it's very worthwhile. I think the coordinators have come out to Camas, they've come out to North Country, they've come out to 3 and given the crews instruction. I don't think we have any patients right now, curiously, right in the city of Vancouver.
There's a lady that dropped off paperwork to Station 8, and she lives on Park Crest. Her husband took a fall, and we wound up, she gave us all her history, so I was like, why does this look familiar, the address? And she had just dropped it off that morning,
Oh, okay.
so.
So, did you have any contact with the coordinator? We should probably get in touch with the LVAD and have them come out to, at least out to 8
There was a whole packet of information.
and give them, yeah,
Just like this.
packets of information are one thing, but having somebody come out and actually give you a, you know, first person, and that way you get to know who one of the coordinators at least. I mean, the coordinator is not going to be on 24/7, but, you know, they have 3 or 4 or 5 that will rotate. But at least to know those. If they have and the caregiver is trained too, so bring the caregiver in along with you in the ambulance.
Is there during volume resuscitation of this LVAD patient, are you looking for a 250 mil bolus reassessed?
Yeah.
Or
Yeah, I would do your standard standard fluid challenges, knowing that the primary problem that you're not having, if you have a volume depletion, you need to get enough volume into the venous side in order to prime the pump, if you will. Just like anything else, it's you know, it's your venous capacitance that has that you need to replace the volume to. Okay, I'm going to hit our cardiac arrest protocols real quickly, and then we'll take a little break, and then we're about halfway done. Okay, continuous compression CPR will be maintained until ROSC or termination of code. This is your basic protocol. Now, I like continuous compression CPR. Now, I'll be very honest, the studies have not shown a significant difference between the old 30-2 and continuous compressions, except that as soon as you get an advanced airway in, all the protocols go to continuous compressions. And because we're putting the iGel in so quickly, with the CO2 monitoring, that's in between. That's an in-between advanced airway. That's really an advanced airway. It gives better delivery of oxygenation, and it doesn't seem to have the blow-by problem you do when you're doing continuous compressions with ventilation. Most of the time, I like to see, and you'll note in our protocol, that continuous compressions occur in your first sequence, and I don't talk about doing any airway management other than a high flow O2 in that first round. It's after the second round, it's after that first shock that I'm going to consider adding BVM and adding an airway device. Drug selection and administration is always based on the last analyzed rhythm. So during that time period where you're off the chest after you've had 200 compressions, you come off and they analyze the rhythm. If it's VFib, then you do drugs appropriate to VFib. If it's not VFib, you consider drugs appropriate to that rhythm. Don't pause compressions to confirm rhythm unless the patient starts grabbing your hands right in there. So if you're at 100 compressions and the guy reaches up and says, "Stop that," I'm perfectly okay with you looking at the rhythm at that point. But otherwise, we look at the rhythm. We don't have a machine yet that does a good read during compressions. So, to recapitulate the VFib pulsus VTAC algorithm, so a treatable rhythm. If they're unwitnessed, we do CPR for 2 minutes, then defibrillate as below. Now, if you arrive on the scene and you have bystanders doing good CPR, you can take a look at the rhythm immediately. In a witnessed arrest, ordinarily we mean witness that you witnessed the arrest, and those are the ones we should have 95% survival. Initial defibrillation, 200 joules, and I recommend, if possible, AP placement. If not possible, do the standard placement, and you escalate from that point on. You increase your output until you're at the full output of the machine. And the sequence in our machines is generally 300 to 300 is the next one, and then 360, full output. IV started, or IO, with salt solution, an I-gel, or an ET tube if that's appropriate. And drug therapy. With each drug, CPR for 2 minutes, analyze and defibrillate as needed. First drug is epi, 1 milligram IV or IO. You can repeat epi every 3 to 5 minutes. CPR, analyze if VFib or pulsus VTAC persists, and amiodarone brings up the question, how about lidocaine? I prefer, it's in your orders, the amiodarone, so unless you want to come talk to me, we'll keep it with amiodarone right now. If you suspect an amiodarone 300 milligrams, IV or IO, and repeat it after 3 to 5 minutes, if they persist in pulsus VTAC or VFib, despite shocks, despite that drug, if you're giving it IO, I'd let it go at least 5 minutes. Then you can repeat it half the dose, 150. If there's torsades or magnesium deficiency suspected, so torsades, mag sulfate, 2-gram bolus, IV, easy way to do that so you don't have to think about it, dilute it, and then run it wide open. Now, can you bolus it? Sure, you can bolus it. You can't hurt a dead person. Normally, you're going to give magnesium over a 10 to 20 minute period. I don't want you doing that in a cardiac arrest. You give it quickly. Continue CPR, analyze, defibrillate, repeat the epi doses as needed. If you get ROSC, maintain your O2 sat of at least 94 to 96, under 99. So 94 to 98. ETCO2 of 30 to 40, 35 to 40 would be better. Monitor your waveform. So you make a decision whether you're going to transport the patient based on a number of things. Like I say, right now we generally transport, especially if people have gone from VFib to an ROSC, then back to VFib, we generally transport those. If you get an ROSC and you transport the patient, you should have if they've been a VFib, make sure you keep the patches on them and be prepared to start doing CPR and shock en route, because they probably do. Now, I'm trying to analyze a couple of different scenarios or different papers. It may be, if we have someone who goes in and out of VFib, you've already given them, or if you have ROSC, it may be reasonable to consider giving them a dose of lidocaine to keep them stable. I haven't decided. There's conflicting evidence out there. I'll bring that back to you at some point. Asystole, straightforward. Determine asystole, continue CPR, IV, ET tube, or an iGel, capnography throughout. If the patient bradyed down in front of you, then you might consider putting a pacemaker on. Or if you gave them adenosine and you failed to check to see that they were on anti-seizure meds and they go to an asystole, you may give them, you can pacer them at that point if you caused it. Drug therapy for asystole, straightforward. Epi, a milligram IV or IO, repeat every 3 to 5 minutes, continue doing CPR, monitor that. Try to get your O2 sat in the 94 to 96%, particularly if you get ROSC, you want to keep it at that level. Follow your protocols if you have ROSC. PEA, also straightforward. IV, IO, volume challenge now for PEA, because it may be due to volume depletion. iGel or an ET tube, capnography, treat the cause. We'll look at the next slide here. And then epinephrine, if witnessed, if they brady down on you, you can consider a pacemaker, but what will a pacemaker do? The thing is already, unless they're bradycardia, you can consider a pacemaker. The cause of PEA can also be the causes of any cardiac arrest. Hypovolemia, you treat that with volume. Cardiac tamponade, we haven't seen the need to continue training on cardiocenteses. So the trick is to drive fast, get them to definitive care, but tension pneumothorax, which is much more common, needle decompression, hypoxia, you ventilate the patient, drug overdose, if there's an antidote, such as Narcan, hyperkalemia, you've got a hyperkalemia protocol, acidosis, ventilate the patient, which is the better, and if you think there's profound acidosis because they've been in a cardiac arrest forever and you've been doing CPR forever, or because it's a near drowning kind of situation, or if it's an arrest due to asphyxia, you might consider that they have acidosis and they could use a little bicarbonate. But generally, ventilation treats most of your acidosis. With a massive MI, they need pressor fluids, etc. Pressor and fluids. So if their left ventricular output is very low, they need norepinephrine. Massive pulmonary embolus is treated primarily now with embolectomy, sometimes with TPA, but mostly embolectomy. And actually, we've had a couple of cases that, with good CPR, we've gotten return of spontaneous circulation, and they've gone to interventional radiology and had an embolectomy. Hypothermia, obviously you warm the patient. Post-resuscitation, if you're going to transport the patient and they're not awake, I want them intubated, even if you had an IGL into. Now, if because of the personnel, if because of issues you can't intubate the patient, if you're going to if we ever get to the point where we would transport any of our patients on a Lucas type device, which I'm not advocating yet, then they all those patients have to be intubated. If they're persistently hypotensive after, now remember, anybody who you resuscitated from a cardiac arrest is going to have hypotension to start with for that first 1 or 2 minutes at least. If they persist in hypotension beyond, let's say 4 to 5 minutes, then they probably need a fluid challenge first, and if they're refractory to that, particularly if the systolic is less than 60, so their MAP is significantly less than 65, then they need norepinephrine, and start out at 4 mics and work up. 12 lead, if you identify a STEMI, they follow STEMI protocol, but all patients post-resuscitation are going to end up at Southwest anyway. Okay. Any questions? All right. Let's take, at the most, a 10-minute pause. Hey, some protocol changes. These are protocol changes for the paramedics. Couple of you've already heard most of this, so I'm just going to refresh on ketamine for RSI sedation. It's 2 milligrams per kilo with a max of 200. For pain control as an adjunct with fentanyl, 0.3 milligram per kilo over 2 to 3 minutes with a max of 25 in each dose. But I want you to have given at least 2 doses of fentanyl. Now, Multnomah County requires 200 milligrams or micrograms of fentanyl to be given, and I'm not going to require 200. So if you gave 2 50s and they, if it's a reasonable sized person, then you can sneak the fentanyl. Now, a lot of people are getting nervous about the use of ketamine because of, they say, well, you get increased nausea and this, that, and the other thing. Well, I'm not sure that's been our experience at all. So we'll just keep monitoring it. I will monitor all uses of ketamine. But now for pain control directly, and this comes, I basically have adopted what the military says, because the military uses ketamine a lot in the field now. For pain control, particularly if you have hemodynamic instability, which means a MAP of less than 65, 0.3 milligrams, so the same dose as we do for an adjunct, but it's given by itself. Give it IV or IO over 2 to 3 minutes with a max of 25, or, and this comes from the military, because they don't always have an IV in there, 1 milligram per kilo IM for pain control. You can repeat that every 30 minutes to control pain, or the endpoint of too much ketamine is nystagmus, agitation, and we've had one case at least recently where the person was really wacko, or ventilatory compromise. Just too much sedation. Ketamine doesn't generally compromise your ventilation because it's just when there's too much. So we want to use it sparingly and with control. Like I say, I will monitor each dose, not each dose, but each time you used it. Now, CPAP. Some minimal changes. Pre-hospital indications are primarily congestive heart failure, pulmonary edema, non-cardiogenic pulmonary edema of any cause, respiratory insufficiency of any cause, such as asthma, COPD, pneumonia, CO poisoning. It works really nicely in CO poisoning. Decreases your total time to clearance by at least 300%. 1/3 is a long time. You can use it in pediatrics if they're able to cooperate and tolerate the procedure. Obviously, a little kid can't do that. Contraindications, absolute contraindication. Don't use it in cardiac arrest or agonal respiration. Duh. Don't use it if the patient's unconscious. If you know you have a pneumothorax, it's not a good idea to have increased intrathoracic pressure, back pressure on the, intrabronchial pressure, because you're going to increase that, make the pneumothorax a tension pneumothorax. Facial anomalies, so burns around the face, fractures, that's things that makes it difficult to hold that mask on, facial trauma. Relative contraindication is a decreased LOC. I don't know how many of you have gotten to the hospital and you think, well, gee, I wish I could have put this person's not very much awake. They're a little bit, they're semi-coma, but they're really short of breath, and I wanted to give them more, and I was giving them positive pressure with a bag valve, and the RT puts a BiPAP on them, and it works well. You guys you're paramedics. I trust you. You know when a person is not doing well on a CPAP. So relative contraindication is decreasing LOC. They're decreased LOC because they're hypoxic and hypercarbic. Claustrophobia. So that's a relative thing. We can deal with that. Patient intolerance to equipment. Tracheostomy if you don't have the right adapter for it, pediatric patient who can't tolerate the procedure, they can't cooperate with you. Hazards of CPAP, gastric distension, corneal drying, hypotension, and pneumothorax. So COPD and asthmatic patients don't respond predictably, so it requires paramedic judgment to do it. The higher risk of pneumothorax, assess lung sounds. If they're not doing well, quit. Increased central thoracic pressure with hypotension. So if you get you decrease venous flow and the patient becomes hypotensive. How we can manage that is sometimes by reducing the ventilation rate and volume, particularly in asthma. In asthma, you shouldn't exceed 5 centimeters of pressure either. So put the face mask on, put an O2 device per the manufacturer. Pressure starts at 5 centimeters, or you set it for 5 and adjust up. Don't exceed 10 with a CPAP. Reassess patient every 5 to 10 minutes. Consider mild sedation. So mild sedation. If they can't, a good thing is ketamine, 0.3 milligrams per kilo, or Versed. Now, maximum, remember, of the 0.3 for sedation is 25. If you can't maintain an SpO2 over 90%, go to PPV with a BVM and PEEP valve, which we're going to come up next. Remove the face mask for suctioning and for nitroglycerin. For bronchodilator administration for MedNebs, you have a MedNeb attachment for the CPAP, so you don't have to remove the mask. PEEP. The indications for PEEP are hypoxia, pre or post intubation, despite appropriate positive pressure ventilation. So the times that you will really consider using it are people who have congestive failure. Contraindications, cardiac arrest. Relative contraindication, existing hypotension. Because PEEP may increase your intrathoracic pressure, which will decrease venous return. Now, you can use PEEP also often to prepare a patient for RSI, if they have a low SpO2 already. And when we get to the RSI thing, we've got some additions that include that. Precautions, hyperventilation, increases intrathoracic pressure and hypotension, and it increases the risk of barotrauma as well, pneumothorax. Put the PEEP valve to the bag valve device. For congestive failure pulmonary, start out with a PEEP of 5 centimeters. Bag is usually can increase by 5 centimeters every 3 to 5 minutes to resolve hypoxia. Max PEEP is 15 centimeters of water. In COPD, asthma, and obstructive lung disease, though, start at 3 centimeters and increase by 3 centimeters to a maximum of 9, so less than 10. Remember, the max on your CPAP was 10. Maximum pediatric pressure is 5 centimeters. Try to maintain a MAP greater than 60. All right, a couple of changes on endotracheal intubation. We've simply added a few things which you already knew but made it easier to understand or follow. Indications for endotracheal intubation include respiratory insufficiency, airway obstruction, unable to protect airway, and a GCS of less than 8, or anticipated clinical course, for example, airway burns, anaphylaxis, etc. Pre-oxygenate the patient if they're less than 90 SpO2, do a BVM assist with 100% O2 until you get to 94%. SpO2 greater than 94%, nasal cannula oxygen only. I like for patients who are in a cardiac arrest to do apneic oxygenation if there's no obstruction, so put that nasal cannula at 10 to 15 liters per minute. Suction is needed. Now, when you're intubating the patient, I want you to start thinking about these. Position patient head of bed elevated to 15 degrees. Now, if you can't elevate the head of the bed because the patient is a trauma patient, elevate the entire gurney. Put them in what's called reverse Trendelenburg. Remember, Trendelenburg is tipped down. Reverse Trendelenburg is tipped up. That also makes it easier for you to intubate. Align the ear with a sternal notch. Okay. No changes in atropine, no change in lidocaine, except that we use lidocaine for patients only with reactive airway disease. It's not indicated for head injury anymore. And if it's too cumbersome for you to do it, I will not beat you to death if you don't use it. You don't have to come see me. If you say, hey, but you should probably let me know. Reactive airway disease, I didn't use it because didn't have time. It's time. Etomidate is still your preferred sedative for intubation with an alternative of ketamine, 2 milligrams max, 2 milligrams per kilo with a max of 200. Now, I recommend it, considering it for status, for reactive airway disease, and in patients who are in shock due to trauma or cardiac or sepsis. Now, you notice that Versed is not there as a preferred. Now, if you have nothing else to use, if they say, oh, if there's a tag on them that says I'm allergic to etomidate and I'm allergic to ketamine, okay, you can still use Versed, but write it in as let me know that there was a problem. Versed is not considered now. Now, RSI, we use sucks with an alternative rock uronium. We can still get it. There's a couple places in Washington that they have run out of rock uranium and can't get it, and they have to go use another alternative, which we worked out for them. We haven't had to do that yet. Rock uranium would be indicated if you knew the patient was hyperkalemic or highly suspected it, because they were on a furlough from their dialysis, or myasthenia gravis, things like that. No other changes. Succinyl choline is still our drug of choice, though. If intubation's repeatedly unsuccessful, insert I-gel, or if unable to ventilate the patient with the I-gel because of patient trauma, severe angioedema, you can't get the I-gel in, etc., then we have to consider a crike. Treat bradycardia with atropine, no change. If no ETCO2 reading or deteriorating waveform, pull the tube and reattempt. Post-intubation, now here's the change. Post-intubation, midazolam for sedation, so if the patient starts moving around, sedation, 2.5 to 5 milligrams of midazolam if the MAP is at least 65. May repeat. If agitation or combativeness persists after sedation, or if their MAP was low, fentanyl, 25 to 50 milligrams every 10 minutes as needed. Case in point, the last lecture, the young woman who had a cardiac arrest was successfully returned to spontaneous circulation, did not wake up yet, was RSI'd and intubated, was given sedation. She began still fighting the tube, got 50 mics of fentanyl, totally quiet, went the entire way to Portland to a pediatric hospital. Another case, a cardiac arrest, fighting the tube, got a long-term sedation. Took forever for us to figure out whether the guy was going to wake up or not. I would much rather see them have the low-dose fentanyl so we can sort it out. We're not doing definitive, I'm going to send you to the ICU on a ventilator in the field. That's not our job. Our job is to get them to the hospital in a good state where we can finish up the evaluations. Now, so then the change is, okay, we didn't get this one in here. So I only want you to use long-term paralysis if it's really indicated. So by the time you've treated with Versed and with fentanyl, most people in Vancouver proper will probably be at the hospital. So you probably don't need to do long-term paralysis. I would not use long-term paralysis if you're trying to see whether you're, just to maintain your airway on a patient who's a cardiac arrest, if you can do pain medication and sedation to maintain them. When you do long-term paralysis, so the orders are going to be much more restrictive for the use of long-term paralysis. Okay, change in flu season only. This is just our SOPs. We are flu season now. Flu season has been officially declared about 4 weeks ago now. So we do have available, if you have badges and you've had your shot to get the little sticker thing which will get you into the hospitals. Personnel who are not vaccinated against the flu, and how effective is the flu, I did look it up for the thing. The current estimation for the effectiveness of this flu is between 40 and 60%. There's a 6% number out there, 6 or 10% number out there, which comes from Australia, and they were only looking at the effectiveness against H3N2, which is only one of the flus in the thing. The 3-pack is not as good as the quadrivalent, the 4-pack. So if you're going to get one, get the 4-pack. So we estimate 40 to 60%. It's hanging right around 40 right now, but that's because the H2N3 hasn't come in. So we'll see how this works out. Nevertheless, if you've had your flu shot, even if you get the flu, it decreases your, it supposedly decreases your length of symptoms and severity of symptoms. We'll see how that works out. If you get the flu, you're going to have a fever. If you get the flu, you get flu symptoms with a fever, get started on antiviral medication, Tamiflu or one of the others. So personnel who is not vaccinated will follow standard infectious disease prevention during patient encounters, including wearing a mask for any patient contact, entering any closed space, including a private residence, SNF, clinic, patient transport vehicles, or entering all hospital facilities. You will be asked to put a mask on if you don't have one on, if you don't have your little sticker that says, or some way of identifying yourself as having the shot. And we trust your judgment and veracity to be honest about it. Big deal. Put a mask on if you don't want to get the shot. No one can make you do that. I'm not going to talk about SUDS. That's really a issue for AMR anyway. Nothing has changed. We draw a blood sample. AMR should draw a blood sample on any sudden unexpected death, including ROSCs, and refrigerate it, fill out the paperwork, turn it in at their office. All right, we have some fairly interesting case reviews here. Anybody have any questions on the orders before we move ahead? We've already sent out a summary to your agencies of the changes, so you don't have to remember everything I said today, unless you come to my office. Okay.
Can I ask?
Yep.
What is the current edition that got? Is it July 17th?
Yeah, and so you should,
Ask that question again.
it's July or August of 17.
The current,
Yeah.
our current protocol version, is it?
There were iterations that were made in both. So the current ones you should have are August 17th, but these are out to your agencies right now.
Yep.
So as soon as you drive home, they're basically in force. And it should say January 18th on the cover sheet.
Yep. Okay. Priority 1, dispatch on an unconscious 78-year-old male at a fitness center. The employee at the facility says he was downstairs. He heard a thud above him on the second floor. He ran upstairs, found the patient lying behind the rowing machine with a pool of blood around his head. He began CPR after calling for help, did a round of CPR until an AED arrives, was applied. Staff states they shocked the patient one time and resumed CPR. E9 arrives to find the patient lying supine on the floor behind the rowing machine, CPR in process, pool of blood approximately 100 cc's. GCS, of course, is 3. CPR is going on, and iGel is put in size 4. IV started. blood glucose is 100, CO2 is 51, because that eye gel is in there and working good. Epi is given. Went right to the thing because one shock had been given. And he continued to be in apparent arrest, so that's the correct thing. And you know, if one shock has been given, you know the machine said it won't shock unless it's VFib. Got epi. Then it says shock number 1, but this is shock number 2, your shock number 1, ventricular tachycardia. Got some more epi. Could have had amiodarone at that point. Shock number 2, then got amiodarone. Came back with an ROC, blood pressure 165, heart rate 88, MAP is 128. Gets full spinal precautions because he got this whack in his head and blood all over the place. Extricated down 2 flights of stairs. He got some midazolam for sedation and then had spontaneous ineffective respirations. The blood pressure is falling, etc. Decided to intubate. He's not awake. Intubated. Got succinylcholine, intubated, lung sounds are cleared. Transported, gets pulseless electrical activity, gets CPR, got some more epinephrine, continued pulseless activity. So arrest. Gets to the hospital. Interesting case. Really nice work in the field. Lots of rounds of CPR, including the ambulance. This would have been a good case for transport with a Lucas device that can do CPR for you in the back of a machine, of a rig. He maintained ROSC in the ED, but required an epi drip to keep his blood pressure up. Because he had so much issue with, you know, his 12 lead is actually, I've looked at his 12 lead and I think he had an inferior MI. It's not 100% conclusive, but in this setting I would certainly say that. But because he was so unstable, they didn't think they could, the intensivist didn't think he could take him to the cath lab. So they stabilized him. He went under therapeutic temperature management, hypothermia protocol. In 24 hours, he's moving all 4. He was extubated, did reasonably well, a little short-term memory loss, and a little aggressive behavior, which responded well to medication. Ultimately, after about 3 days, 4 days, he had a PCI, ended up with getting 2 drug-eluting stents. And his wife said, I don't want to take him home because I'm scared. So they put him in a SNF. As far as I know, he's at home now. I think she was afraid because of his medical problems, not afraid of him. It's a good case, but it goes to show that, you know, you don't always respond to the first AED shock or even the second. Now, here's a 25-year-old male found pulseless and apneic by his wife. Wife states the patient took some oxycodone before going to bed. Minutes later, she found him unresponsive with no pulse and not breathing. Dispatch had her start CPR. He's found in the bedroom, supine, pulseless, and apneic. Dusky cyanotic extremities, compressions, continued BVM ventilation. Pupils were noted to be slightly constricted. Given the first dose of Narcan at 2 milligrams. Eye gel was inserted. Ventilation is positive, capnography reading of 25. An episode of emesis with minor purposeful movement. Additional Narcan of 4 milligrams was given. And within minutes, He had another episode of emesis and coughed up the eye gel. Able to answer all questions correctly, loaded in the rig during now this is not put into our cardiac arrest statistics. This is not part of the CARES thing because this is a narcotic overdose. During transport, IV established, given fluids, denied headache, dizziness, chest pain, dyspnea, abdominal pain. Does remember taking oxycodone prior to falling asleep because he wanted to. Good reason. He didn't say how many he took. He took enough that it took, basically 4 milligrams of Narcan. Patient's extremities continue to be dusky. Now, so blood glucose, okay. Okay, he's in this one, he is now awake and talking to you, and he has a pulse ox of 54. He gets oxygen at 6 liters per minute. Anything else we could have done for him at that point? Anything else? What's common after a narcotic-induced respiratory arrest with treatment with naloxone? Non-cardiogenic pulmonary edema. And his pulse ox stays low. We managed to get him all the way up to 83, which isn't normal. So this is a great case. He ends up in the ED with an SpO2 of 80% in the ED, 83 the last on the EMS. He had pulmonary edema on exam and on films, which is just adult acute respiratory distress syndrome, non-cardiogenic pulmonary edema from the arrest and re-expansion after eating Narcan. He may have had some aspiration pneumonia too. He did well in the ED and in the hospital on BiPAP, so he never did get intubated. Turns out he has a lot of other issues. He has a clotting factor deficiency. He had a previous DVT and pulmonary embolus. And he's been taking oxycodone instead of Coumadin. So he was put on heparin prophylactically, and then he's probably on Coumadin now. So he'll probably overdose on the Coumadin too now. But you'll probably see him again because he just wants to, take his oxycodone in large chunks. And he's probably found somebody in the community that will write him a prescription for 100 or so at a time. Okay, dispatch code 3 on a cardiac arrest. Family says they were sleeping in bed, so the spouse woke up, patient not breathing. Denies that the patient is taking any drugs, but did have some alcohol. VPD was the first to arrive. They were simultaneously dispatched. The VPD had a defibrillator, an AED. Patient had no pulse, started CPR, put on their AED, which advised a shock. Twice. So there was apparently really early arrival, and then the first fire or ambulance did not get there for a long enough time that they got time to get 2 shocks in. VFD arrives, and then on their arrival, the patient's in a PEA. So CPR, I-gel, pulse ox, glucose is okay. Starts after these things, didn't require any medication, has still GCS of 3, blood pressure of 129, pulse 138, MAP is 94, got some naloxone IV, and then kind of bucking around, so ends up going to be transported, gets accommodate, sucks, and intubated correctly. First pass. CO2 is 27, 12 lead shows a normal sinus rhythm, no evidence of acute MI. Got some midazolam and transported. CO2 is now 32, so she's doing well. In the hospital, she's still comatose. Now, we have the advantage of having past history on her and there, and she has an unusual history of seizure-like activity after alcohol or cocaine. Her urine drugs are positive for both. Well, positive for the cocaine, but we don't, her husband said she did have some alcohol. She did not have a measurable blood alcohol. She has a history of unusual seizure activity, and she's followed by OHSU neurologists. She has some anti-seizure medication. In the ED, she maintains her pulses. She remained comatose, but appeared to be having some odd tonic-clonic kind of movements, which were thought to be possibly seizure activity. She's given some Keppra and some fosphenytoin. She should have been on Keppra. That was her drug of choice, her drug from OHSU. EKG was negative ×3. She's negative on all her enzymes. Her head CT was okay. And she was ultimately transported to OHSU for further care. I've done follow-up on her. I had follow-up done by Dr. Hanley, and she was at OHSU for 2 days. They did sign her out, interesting enough, as a non-STEMI. She's got normal coronaries. She's supposedly on medication, but I did check also, she has failed to make any follow-up appointment with either the neurologist or the cardiologist. Shocking, right? Now, the interesting thing about this is that I was quite upset because between the ED and see, it works all ways. Between the ED and the neurologist, they decided that the AED must have mistaken this seizure activity for VFib. Impossible. Or the manufacturer would probably want to have some say about it. So we went out to interrogate the machine. And of course, by protocol, the battery had been changed, so there was no more record. So we're going to rewrite the protocol so that if VFD has, or the sheriffs use an AED, that the machine is turned in and we interrogate it immediately before they have to change the thing. Because, this is just an error. There should not have occurred that way. These AEDs do not make mistakes. They will not tell you to shock a patient because they're having seizure activity. Just like you can't do it if you do any motion to the patient. So, all systems have to. So I am also taking care of educating all the ED docs to know that if you have an AED go off, that is considered absolute evidence that there was VFib. You can't write a murder mystery where you kill someone with an AED because it won't shock accidentally. All right. This is the famous Chick-fil-A parking lot incident. VPD, VFD are on scene beside a white pickup truck. They see VFD wrapping a patient's hand in gauze and are directed to patient number 1, who is laying on the ground outside the pickup truck, passenger side. He has his left foot propped up on the cab of the truck, and there's a tourniquet, a manufactured tourniquet out of the other person's T-shirt on the upper thigh. VFD is cutting it off and putting a sterile bandage on it because this wound is not pumping. It's an upper anterior thigh. Patient, it's his birthday. He's 23. He and his cousin went to the shooting range to celebrate his birthday. On their way back, cousin, the passenger, releases the clip, didn't realize there's still a bullet in the chamber. Now, fires the gun through his own hand and ultimately through the patient's thigh. They drove another few blocks and then went to the Chick-fil-A. They could get a snack, I suppose. And one had a hole in the hand, one had a hole in the thigh. They called 911. They say no drugs, no alcohol, and no animosity. Well, I believe the latter, but not the first two. So they had a tourniquet on, they took it off, they just put a pressure bandage on because this is not a pumping wound requiring a tourniquet. This is, and I was asked earlier, do I approve of you guys taking off a tourniquet, even if it's been put on by the police, putting a dressing on and evaluating it? Yeah, that's what we pay you for. He got some fentanyl. Then he became a little nauseated, or wasn't nauseated to start with, so got some ondansetron. And then transported for a full trauma activation. Well, I'm not sure this fits a full trauma, but we've had a couple of leg wounds or at non-compressible or poorly compressible sites that have been a problem in the past, so it's no big deal. They always get excited. Even if you took them in as a trauma alert or a modified trauma, you would be seen immediately by the trauma surgeon, so it's not a big deal. And what did they do? Well, they cleaned the wound out and sent him home. He has some fragments in there, but that's all you do more damage digging around to take bullet fragments out. People live with shrapnel all the time. If they get infected, comes squirting out like a little splinter. Now, this is Mark's comment. We're surprised how they survive the shooting range if they leave with live rounds in a gun. So we're going to give this one the Darwin Award for the year. And we'll probably do a Darwin Award every. Now I'm not sure that actually the first drug overdose and the second seizure lady also don't get Darwin Awards, but it's a toss-up. Okay. So. Any questions, any thoughts, any ideas? We will see you. We'll see you at the stations next month.